The two different drugs have very different mechanisms of action. There's no reason to think that they wouldn't be complementary, and I should mention that both drugs are being tested on a background of ACE inhibitor or angiotensin receptor blocker therapy. So they're being tested on the background of standard of care therapy looking for additional benefit. The two drugs are in different stages of development. Alpha V beta 3 integrin inhibitor is a phase 2 development program, and it's a parenteral therapy. It's a monoclonal antibody. So it's a different type of therapy with a different type of administration than Invokana, which is a drug that's approved for the treatment of type 2 diabetes and is in a phase 3 program. It's a pill. It's orally taken once a day. So I think between the complementary mechanisms, the different routes of administration, and the different phases of development, these two modalities will over time sort of prove themselves for how they best fit into the armamentarium for physicians and patients to be able to treat diabetic kidney disease. With Invokana, the adverse effects are fairly well understood. We ran a greater than 10,000 patient phase 3 program with Invokana before its approval, and then we have, of course, many studies running afterwards. The main side effects of Invokana have to do with urinary tract infections, genital fungal infections, and the results of the diuresis and the possibility in some patients of getting dehydration from this mechanism. We are, of course, studying a very specific population with diabetic kidney disease, and so that large clinical trial, the 3,700 patient trial, will tell us more about the specific safety profile in that population. For alpha V beta 3, the integrin inhibitor, that mechanism is still in very early stages because it's a phase 2 study that's being done. So we are very actively watching that program for the safety profile of that mechanism. Invokana is a drug that would be taken daily, and it is taken daily in its current indications. The alpha V beta 3 integrin inhibitor would be taken less often. Right now it's being tested as an every 2-week injection. Injection raises different challenges for patients than taking a pill. Certainly a pill is always easier, both from the point of taking the medication, but also from the point of supplying the medication and being able to have a device for the medication to be administered to the patient. Nevertheless, injection therapy is something that is extremely common in diabetes. After all, the first therapy for diabetes was insulin back in the 1920s, and that's an injection-based medicine. So patients with diabetes and their care providers are very familiar with injection therapies. It's difficult to predict the actual price of these drugs when they are, if they are eventually approved. Certainly, we would expect that because of the innovative nature of them and the benefit risk we're looking for, where we're looking to really have transformational effects on patients and their disease, that the pricing would appropriately reflect the innovation that we'd be bringing to the patients and their providers. Dialysis is ultimately the treatment for most patients with end-stage kidney disease. Transplantation is also a treatment, but is certainly limited by the availability of resources, including the availability of kidneys. I think it's important to note that if you look at the number of patients worldwide with end-stage kidney disease or end-stage renal disease, that number is currently estimated to be between 5 and 10 million patients. We know that the number of patients getting dialysis or transplantation worldwide, and most of that's dialysis, is about 2.5 million. So what we know, in the United States we have very good access to dialysis, but that's not true everywhere in the world. So as this epidemic of diabetic kidney disease is increasing, we know there are millions of patients out there who are dying from lack of any treatment for their end-stage kidney disease. And that's part of why it's so vital to come up with new ways of preventing the progression of diabetic kidney disease. Once you have end-stage kidney disease, dialysis and transplant are your two options. And if you look at the mortality curves for patients with end-stage kidney disease, it's really a terrible disease. The morbidity and mortality of this disease are very, very high. And again, the real key is to prevent patients from getting to that point. The unmet medical need in diabetic kidney disease is enormous. And it's really a time now that we can apply scientific advances that have been made over the past decade to bring new therapies, transformational therapies to patients. It's really been quite a long time since the advent of the ACE inhibitors and the angiotensin receptor blockers since we've had anything new to give patients with diabetic kidney disease. And so I certainly look forward to the advances that we are on the cusp of being able to make for these patients.